Medurstand Understanding Medicine.
This is Professor Aziz or Rehman from Medurstand-Understanding Medicine. We are discussing various kidney disorders these days, and this lecture is about nephrotic syndrome. I won't say it is very common, but it is not rare either. It is actually a combination of 3 or 4 clinical and laboratory features, but main component of this disease is glomerular disease, which results in massive proteinuria. So it is defined as there are 4 conditions. All of them may not be present. Of course, as a student, you would like to have all of them to be present to legally or formally label it as nephrotic syndrome. But as a clinician, I think anybody who has massive proteinuria, from diagnosis purposes and also from further investigation point of view and also from the treatment purposes, I would treat anybody with massive proteinuria as nephrotic syndrome. So what is massive proteinuria? So of course, microalbuminuria and little bit of proteinuria does not constitute massive proteinuria. What is the exact amount which is required, we'll discuss in subsequent slides. And this proteinuria would result in hypoalbuminemia, although whenever there is protein loss, kidney would also try to preserve it to a certain extent, and liver will also try to make more protein by increasing synthesis of albumin and globulin, but still there would be hypoalbuminemia. So that is the second component, and after that this would also result in generalized edema. As I would discuss in more detail in the subsequent slides, albumin is required to maintain oncotic pressure. Oncotic pressure keeps the fluid within the capillaries. So once oncotic pressure is dropped, fluid tends to leak out into the tissues. That results in generalized edema. So, and that the fourth component of nephrotic syndrome is the presence of hyperlipidemia. Now this is because whenever there is increased production of protein, there is also increased production of lipoprotein. But I would not actually require the presence of hyperlipidemia to label somebody as a case of nephrotic syndrome. So practically speaking, for the purpose of diagnosis, for the purpose of further investigation and the treatment, I think anybody having large amount of protein excreted in the urine should be provisionally labeled as a case of nephrotic syndrome. But as a student, if you're asked what is nephrotic syndrome, you have to tell all 4 components. All of them may or may not be present, but of course proteinuria will always be present. Now I'm going to discuss all of these in more detail. First of all, let's see proteinuria. Disruption of normal glomerular barrier due to any of many causes. Now, in my introductory lecture, I told you that the glomerulus has got very small fenestration on the endothelial capillaries. They allow only the fluid and the electrolytes. They do not allow large proteins, and they do not allow any cells, and they do not allow even albumin. Very small amount of albumin may leak into the glomerulus, but that is reabsorbed. As a result, almost nil albumin appears in the urine. But once this glomerular structure is destroyed by mostly immune complex disease and also by other mechanisms, so this protein, which is part of our plasma, that will filter into the glomerular tubules and then further excreted into the urine. Proteins, especially albumin, is filtered through the nephrons. Albumins, because of 2 reasons. One, albumins are relatively smaller molecules than globulins, and number 2, albumins have got negative charge, and endothelial cells also have negative charge. Normally negative charge repels negative charge, but in glomerular disease that negative charge of glomerular epithelium is lost, and that would not then be able to stop albumin filtering into the glomerular tubules. Of course, there could be mixed proteinuria, but there are some cases, especially in the minimal change disease, there may be more albumin. If the albumin is more than 85% of the total protein, it is called selective albuminuria. So there would be mesoproteinuria, 3 grams per 24 hours. So you would require to collect 24 hours urine and see what is the total amount. It has to be 3 grams or more. So why do we need 24 hours? Because sometimes urine may be dilute, sometimes urine may be concentrated. So spot urine may not be sufficient to make a diagnosis. But to correct for that, there is another plan. I think that is definitely better if there is more than 2 grams of protein per gram of creatinine. Now, this creatinine would actually reflect the level of concentration. So, in any spot urine, if there is 2 grams of protein per gram of creatinine, that would also be diagnostic. I think the first sample in the morning would perhaps be the best. Or with the dipstick method, 3 plus proteinuria, because this is the first line investigation. Whenever we test somebody's urine, and this is the dipstick method, so if that shows 3 plus proteinuria, I think that would be definitely nephrotic syndrome. You know, protein in the urine can come from other sources, like it could come from the urinary bladder, ureter, urinary pelvis, or sometimes vaginal fluids may contaminate urine. So all these could give you some degree of proteinuria. Uh, in interstitial nephritis can also give you some level of proteinuria, but 3 plus is seen only in glomerular disease. So in fact, 3 plus proteinuria is also called glomerular proteinuria, and glomerular proteinuria is almost synonymous with nephrotic syndrome. But if somebody is passing a dilute urine, somebody has taken a lot of water, and if you test urine with dipstick, I think 2 plus would also probably indicate the same. So I think any of these methods, this is perhaps more definitive but cumbersome, and often urine collection is not accurate. I believe this one is best, 2 grams. So you ask somebody to have the urine tested for both albumin, protein and creatinine, and you apply this formula. If it is more than 2 grams per gram of creatinine, you have made a diagnosis of proteinuria as a component of nephrotic syndrome. So this was it. Now let's take hypoalbuminemia. Of course, there could be hypoproteinemia, but liver synthesizes albumin, and globulins are synthesized by the liver, but also by non-liver tissues like our lymphatic system and maybe spleen also, they synthesize globulins. So that is why when there is proteinuria, there is more effect on the albumin. So whenever there is hypoalbuminemia, liver would try to compensate by producing more albumin, and liver has got a lot of capacity. Liver may take some time to adjust to this situation. Of course, there may be a situation in the initial part where there is albuminuria, but liver has not yet started producing more albumin, but soon liver will take up this challenge and will produce more albumin. But of course, liver has a certain secretory capacity. Now, if the protein loss per day exceeds the synthetic capacity of the liver, it would result in hypoalbuminemia. So, and if there is more loss of albumin than globulin, AG ratio, which is albumin globulin ratio, may also be changed. Normally, if you have 6 grams of protein, 4 grams would be albumin, only 2 grams will be globulin. So once globulins are preserved but albumins are lost, this ratio may become equal or maybe actually reverse. So this is how hypoalbuminemia or hypoproteinemia develops. Now third one is generalized edema, and how this develops. This is the capillary. There are 2 types of forces Actually, there are four types. Two types of forces within the capillary which keep our fluid part of the blood inside the capillaries. One is the hydrostatic pressure. More the hydrostatic pressure, more chances are that the fluid will leak out into the interstitium, and that is actually a physiological phenomenon. Fluid has to go to the interstitium with its nutrients, amino acids, and glucose and other things. So that is physiological, but too much leakage is prevented by oncotic pressure. Oncotic pressure is maintained by proteins, mainly albumin. So if albumin level drops, then the ratio between hydrostatic pressure and oncotic pressure will change more in favor of hydrostatic pressure, and more fluid will ooze out into the interstitium. So of course it will happen in the entire body, but in the dependent parts, like when you are erect, that your ankles would be dependent, or when you are supine, maybe your sacral region will become dependent, and also the scrotal sacs. These are dependent parts, so there would be more accumulation of fluid in these areas. So hypoalbuminemia leads to reduction in oncotic pressure and leakage of fluid into the interstitium, and there is also simultaneous retention of sodium. Now, why does that happen? Because once less fluid stays within the capillaries, body system, particularly renin, angiotensin, and aldosterone system, sees it as a hypovolemic state. Because the effective capillary volume, the effective arterial blood volume is reduced. So body sees it as a state of dehydration or volume depletion. So body will try to preserve sodium as well as water. So that will also compound this edema formation. Maybe vasopressor also plays some role in this. So this edema is pitting because it is fluid in the interstitium, and fluid can be easily displaced by putting pressure. So in order to differentiate various types of edema, this edema would be pitting. In fact, it pits very, very easily. You apply very gentle pressure on the shin against a bone near alveolus. You would see that this, sorry, not alveolus, malleolus. So if you apply some pressure on the ankle near malleolus, so you will see this pitting formation. Generalized but more marked on dependent area, because in dependent areas the effect of gravity would also be added, because gravity would increase hydrostatic pressure. So I think these are the mechanisms of edema, which is one essential component of nephrotic syndrome. And let's take up this last one, hyperlipidemia. There is increased production of lipoprotein, as you may say, as a byproduct. Whenever there is stimulation of production of protein, lipoproteins are also synthesized in more quantity. So you would have all types of lipoproteins, LDL, total cholesterol, HDL, and VLDL. All moieties of lipoproteins will be increased, and significantly so. Sometimes you may have reasonably high cholesterol, like 350, the type of lipid disorder you get in familial hypercholesterolemia. So I think this component has to be addressed also in the treatment. There is usually mixed hyperlipidemia, because all types of lipoproteins are synthesized in increased quantity. And of course, if these patients are taken care of, nephrotic syndrome, and they live for a long life, there is increased risk of atherosclerotic cardiovascular disease. So I think that needs to be considered. One might overlook this because often this nephrotic syndrome develops in children, and one might overlook atherosclerotic cardiovascular disease, but I think you should look forward to a long life in these patients, and you should address atherosclerotic cardiovascular disease prevention also. So these were the essential components, but there are some additional abnormalities which I think are equally important, at least equally important to understand, because they might also require some further investigation and for some further treatment intervention. Thrombosis, these patients with nephrotic syndrome are at an increased risk of thrombosis and thromboembolic disease. Why? Because when there is increased production of proteins, there is also increased production of clotting factors. All clotting factors are proteins and all clotting factors are produced by the liver. So maybe unintentionally, clotting factors are also produced in excessive quantities that might produce a hypercoagulable state. And there is also loss of antithrombin T and plasminogen. These are antithrombotic proteins. They may be lost in the urine because sometimes there may be loss of these into the glomeruli along with albumin, and there would be critical deficiency of these two components in the renal vein. There would be, of course, deficiency all over, but maximum deficiency would be in the renal vein, and that is why there is increased risk of venous thrombosis, particularly in renal vein. In fact, when I was a student, I used to read the causes of nephrotic syndrome, and one of them used to be this renal vein thrombosis. Now I was puzzled, how could renal vein thrombosis can cause nephrotic syndrome? Later on, I found out that actually the relationship between renal vein thrombosis and nephrotic syndrome is the reverse. So because of loss of antithrombin 3 and plasminogen, there is critical deficiency of these two proteins in the blood which drains kidneys, renal veins. So that is where the thrombosis is more likely to develop. But of course, it could develop elsewhere also. According to studies, there is 10 times increased risk of venous thromboembolism in people with nephrotic syndrome. So that is very, very high risk. So I think this definitely needs to be addressed. So if you have taken care of a patient with the nephrotic syndrome, you have corrected the basic abnormalities, I think you might consider these also as a treatment intervention strategies. Now the second one is infection. People with nephrotic syndrome are also more likely to develop infections. Why? Because there may be deficiency of immunoglobulins and other proteins involved in immune responses like complements. Complements are proteins. They may also be lost in the urine. So there could be actual deficiency of complement and also deficiency of immunoglobulin and maybe some other proteins, opsonins. So these deficiency could lead to more predisposition of infection, and this is actually a fact. People with nephrotic syndrome, they're more prone to get skin infection, urogenital infection, and other infection. Now the other one in addition is malabsorption. Why so? Because of generalized edema. Of course, this would affect our viscera also. There may be edema of gut wall. The thickness of gut wall from duodenum and jejunum may be increased, and that might interfere with the absorption. And when there is deficiency of protein, that might also affect the absorption of certain or formation of certain critical enzymes. So there may be actually some kind of malabsorption. So there could be additional nutritional deficiency that justifies the regular use of some micronutrients and supplements in people with nephrotic syndrome. Now these are the clinical features. These people are usually very pale because they may be anemic, but actually because there is increased fluid in the skin, the distance between capillary and the skin increases and the red component is diminished. So these children look very pale, and there may be facial edema, there may be generalized edema, pitting edema, and more marked on the face. There may be periorbital swelling, and there may be also swelling on the scrotum. There may be ascites. So these are different types of fluid edemas, and people often describe as passing frothy urine because the protein in the urine would make a kind of emulsion and urine would froth a lot. A little bit of frothing is normal even in a normal person, but in people with nephrotic syndrome there is more frothing. Some children, some individual with nephrotic syndrome might also develop nephrotic syndrome. Now, if you have noticed, nephrotic syndrome definition does not require any involvement of kidney function. But since it is glomerular disease, it is very likely that these patients, they have some degree of hypertension and some degree of renal failure also, if not to begin with, later on. So some patients would also have hypertension. So these are the clinical features, and if you test their serum protein, that would be low, and if you test the lipids, that would all be high, and if you test the urine, it would show proteinuria. So all these, I think, will make a diagnosis. So laboratory urinary specific gravity is increased. Why I have listed specific gravity first? Because in the dipstick this is routinely measured, and specific gravity is mostly determined by protein, and there would be 2 plus proteinuria, 2 plus or more proteinuria. There could be more than 3 gram protein per 24 hours if you collect 24-hour urine, more than 2 gram protein per gram of creatinine in spot urine test, and there may be hyaline cast in the urine. If you test it under the microscope, there may not be any cells, or there may be some, but the hyaline casts are made of protein of various shapes and sizes would be seen in the urine under microscope. And serum protein and Ag ratio would be affected. Protein would be reduced, Ag ratio would be altered in favor of globulin, and lipid profile would show a mixed type of hyperlipidemia. And if you do ultrasonography of the kidney, in most cases you might not see any significant abnormality, but an expert person would describe some changes in the renal parenchyma, maybe some swelling of kidney, some abnormality, or some non-specific abnormalities are seen on ultrasonography. Only in advanced disease there may be reduction in size, but not in the initial cases. There may be ascites, there may be pleural effusion, there may be collection of fluid in other third spaces, and there may be renal vein thrombosis. If you do ultrasound, you should be particularly looking for renal vein, and if required, do a duplex scan, because that is better than simple ultrasound to detect the renal vein thrombosis. And if renal vein thrombosis is required, it would probably require some further testing like CT angiography or maybe other kind of venography. So what is the etiology? It could be some disease which primarily affects kidneys, like primary glomerulonephritis, and I've already covered a lecture on glomerulonephritis, but this is just a list: IgA, nephropathy, minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, membranoproliferative glomerulonephritis, and congenital disease. Clinically, you cannot differentiate between these. It is only the overall history, further testing, maybe ultimately kidney biopsy, which will help you to make the difference. The differentiation between these would be important because some of them might require specific therapies, but first line treatment is the same in all cases. Now then there are some systemic diseases, and this is of course not the complete list, some systemic disorders which can also affect kidneys, and I think at the top I would put lupus nephritis. Sometimes people have features of SLE all over including kidneys, but I've seen people who have minimal disease in the skin and the joint, but their main problem is nephritis. So it could be lupus nephritis, diabetic nephropathy. These days when we have so many treatment options, fewer and fewer people they develop nephropathy because we are not able to prevent this. Henoch-Schönlein purpura, this is a rare condition. Henoch-Schönlein purpura is fairly common, but Henoch-Schönlein purpura causing nephritis and albuminuria and nephrotic syndrome is luckily rare. amyloidosis is a mysterious disease, can affect kidneys, luckily not very common, and sometimes drug-induced. Drug-induced kidney damage is more likely to be non-specific interstitial nephritis, but sometimes it could be in the form of proteinuria also. So I think some kidney diseases or some systemic diseases with kidney involvement, they could cause nephrotic syndrome. So in these, the focus would be only in the kidney, but here you have to consider body as a whole to cover to give it proper treatment plan. So I think what is the role of biopsy? Now that I'm going to examine. Although the diagnosis of nephrotic syndrome does not require biopsy, because the components are like they can be fulfilled without kidney biopsy. But I think it is indicated in all patients with new diagnosis of nephrotic syndrome, ideally before starting medication, unless you already know the cause. Like somebody is chronic diabetic and develops nephrotic syndrome, I think we know the cause, maybe kidney biopsy is not needed. But somebody who was previously well develops nephrotic syndrome, I think biopsy should be done. So in almost all cases, because and ideally it should be done before you start specific medication, especially steroids. Why? Because the medication can affect the biopsy changes. So you should do biopsy when the disease is in naive form. And sometimes a follow-up biopsy may be done. Now, especially if you're using an experimental medicine, and after the giving medicine, you would monitor the patient clinically, but I think one would like to see the histological improvement also. So after a certain time, in some cases, a repeat biopsy may also be needed. So this is the technique. Patient lies on the stomach, and because the kidneys are on the backs, these are the kidneys. Special needle is used, and kidneys are localized on ultrasound. People used to do it without ultrasound when this facility was not available, but I think now that this facility is available, below the costal ribs, because the ribs go, that's like half of the kidney or maybe more of that is hidden under the ribs. So lower pole is best to approach, and there are two types of needles which are used, and this is the cut section, this is the kidney. So you go from through the muscles parallel to spines. Of course, you don't go too deep to avoid these vessels. So these are two types of kidneys. I would love to describe their mechanism, but time would not allow me. This is one needle, this is another one. This is called true cut biopsy. And you see there are actually two hollow pipes. The biopsy piece comes here, and through some special maneuver, once this needle is inside kidney, and this outer pipe is pushed forward, and a very nice cylinder of kidney tissue is taken out and from this part. And this is McGinney's. This is called Shortcut, and this has got again one needle and the one hollow thing, and this is also put into the lower pole, and this will literally suck a piece of kidney. This is considered safer for the patient and less traumatic, but this needle definitely gets a better piece. So I think different people have different preferences. This is usually done by a trained nephrologist. Everybody cannot and should not try to do renal biopsy. It is only the trained person, because it could lead to some serious injuries like internal bleeding. So I think this biopsy is must. Only trained nephrologists should do it. Now, once you have made a diagnosis and you have done the biopsy, now is the time to start treating these patients. First of all, conservative treatment. In conservative treatment, there are various things you do. You measure the patient's weight daily so that you see how much fluid water patient is retaining. You measure the fluid intake, you measure the urine output, and you adjust fluid and water intake accordingly. You also give special proteins and you give high biological protein in relatively restricted quantities, and later on you might actually have to supplement proteins. So I think from time to time we change our treatment plan according to the condition, and we try to avoid all those drugs which could harm kidney. So this is conservative treatment, and in conservative treatment also we give furosemide because patient is very much bothered about this fluid retention. So we give diuretics, initially furosemide, but if we have to give it for a long time, we have to add some potassium sparing diuretics, uh, usually in combination, so that patient does not develop hypokalemia. And then steroids are usually very effective, and in almost all patients steroids are given unless from biopsy you know that there is a condition which is unlikely to respond to steroids. Steroid course is usually given to all. I do not go into the details, but it is usually high dose for at least 3 to 4 weeks when we taper it down, and then we try to maintain at the lowest dose. With this technique, you'll find out there are three types of patients with nephrotic syndrome. Those who are steroid responsive. That means you have given steroid for, say, for 6 months, and then you have taken them off steroid and their proteinuria remits and never comes back. So that is the best outcome. That is steroid responsive, as if they have responded to steroid therapy. Then there are people who are steroid resistant. You given steroid in full dose and proteinuria does not diminish. Of course, during this time you are monitoring their urine proteins quantitatively, and if with steroid there is no change in proteinuria, that would be called in the steroid resistant. Little bit response would also mean that they are actually steroid resistant. Then there is a third category. That is, when you give them steroid, they respond. But once you take them off steroid, the proteinuria starts again. So this is called steroid dependent patient with nephrotic syndrome. So based on the type, you would use steroids for a variable period. Once steroids are given and patient has shown response, and then we always try to take them off steroids and we give immunosuppressant therapy as a steroid sparing drugs. And there are various immunosuppressant therapies, and there are many of them which I'm not familiar with, but cyclosporin and mycophenolate mofetil as the commonest drugs given. And of course this would be done by a trained nephrologist. Different drugs are tried, and based on the experience of that particular nephrologist, one or two are given on long-term basis. Along with the steroids, we try to taper the steroids but try to maintain immunosuppressant therapy on long-term basis. Anticoagulants, I think this is still somewhat controversial, because as I told you in my earlier slides, these patients are more prone to develop thromboembolic disease 10 times more. So that justifies the regular use of anticoagulant. So it may be antiplatelet, but actually you need anticoagulant, factor 10 inhibitors or something like that. I think that would be needed. Then lipid lowering agents. Of course, these patients, once they are controlled, you can expect long life, and you have to protect their heart and the brain from atherosclerotic cardiovascular disease. So I think you should treat their hyperlipidemia as you treat any other hyperlipidemia, like you would give statins. Rosuvastatin is perhaps not right for patients with nephrotic syndrome, but other statins are useful, like atorvastatin 10 milligram or 20 milligram, or in patients who do not respond or resistant to or are intolerant to statin. Now we have PCSK9 inhibitors also. So vaccination and antibiotics, as these patients are more prone to get infections, I think routine vaccination, flu vaccine, pneumonia vaccine should be given to these patients, and whenever they develop infection, they should be given antibiotics. I think the threshold of antibiotic may be little lower in these patients. So prognosis, minimal change disease. As if you remember, there's a list of causes of glomerular diseases. One of them is minimal change disease, which is one of the types of post-streptococcal glomerulonephritis. This has got the best prognosis because the chances of response to steroid is maximum in these patients. And they may go into remission, and on minimal dose of immunosuppressant, they may stay in remission for long. Others may not respond to steroids and other immunosuppressant therapy, and they may go on to develop kidney failure rapidly over a period of months to years. And some would develop severe disease, some would have a smoldering disease, others would develop progressive disease ending up in end-stage renal disease and requiring some kind of renal replacement therapy. So that was all. I hope this lecture was useful to give you some idea about nephrotic syndrome, and I covered the basic definition. I tried to explain various components of nephrotic syndrome, and I gave you an outline of the treatment, and I highlighted the importance of biopsy. I hope to see you in my next lecture also. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine.